remember your exams on Monday. Special census and hematology, same format as the last exam, no lecture after. Go from there. All right, so hematology, remember that. Yes, ma'am.
Is this the one where you said there's going to be a weird question where we walk through?
No, that will be the third exam.
Sorry.
Yeah, this one will be the exact same. 50 questions, multiple choice, true, false, fill in the blank, possible some matching. Don't have to leave your chair. That type of thing. But the next one will be the one that has the blood flow question. And it's basically just, it's the same. There's just going to be things that you have to kind of come to grips with in anatomy, like you had to learn the bones, you had to learn the muscles, you had to learn the cranial nerves, you have to learn a certain amount of the blood vessels, because for most of you those would have a pretty good grasp of it.
Sorry, the labeling wise, are there going to be like images on this one where we're like picking out the
Might be a picture of a nose you have to pick. But other than that, no. It'll be the same. I mean, you might have you might have, you know, a picture and it's got this and it's got what looks like might be the middle ear, and then you might have, you know, that's the reason why I'm not a medical illustrator.
maybe a little more specific.
But yeah, I mean, it'll be A. What is A? Oh, that's the pennant. What is B? That's the semicircular canal. So it'll be something like that. It won't be anything, you know, horrific.
Okay.
Just simply because there's really no way to put a diagram on there that's that clear that you can get into too specifics. It's more, do you get the bigger, broader picture? All right, so hematology. Remember that the hemo, hemato, those are all terms that have to do specifically with blood. We will make some distinctions as we move through the lecture today between red blood cells and white blood cells, because but the suffixes are very, very similar. It's the prefixes that change. It's one of the reasons why it's kind of important to get those down. I'm a big fan of having had medical terminology either by the time you complete AMP1 or before you even enter the sequence, because the more you know about prefixes and suffixes, it's easier to at least make some educated guesses if you're not quite sure in what direction to go. And that's the whole point of medical terminology, is it teaches you what the prefixes and suffixes are. So we talked about the functions of the blood. We talked about the composition of the blood, that we have plasma, which is predominantly water, makes up our electrolytes, makes up our respiratory gases, and we have our proteins in there. Remember, most of our proteins come from the liver. What else I want to tell you about the plasma? It generally makes up about 50%. Again, to be a little more accurate, it's about 55%. But whenever you're doing calculations, whenever we do calculations, guesstimating things, we generally peg it at about 50%. When we do lab stuff, not lab stuff here, but when you get into graduate level physiology, then the numbers are very, very specific. Here, it's really to get the idea of what's going on. So understanding that plasma is about half of your circulating blood volume is important. And remember that it's about 5 to 6 liters. It's about 8% of your body weight in kilos. Okay, that's essentially the amount of blood that you're going to be carrying around. Again, a healthy person, somebody who's involved in a trauma. Talked about our formed elements, and our formed elements really are our red blood cells, our white blood cells, and our platelets, our thrombocytes. And remember, I want to kind of keep driving this point home. We call them thrombocytes. They are not cells. They're parts of cells. Okay? So I kind of went through a brief introductory to it, and now I'm going to kind of go back and start with erythrocytes. These are our red blood cells, RBCs. That's basically how they're going to be talked about in a clinical situation. Again, you look at the numbers. I do think it's important to kind of have a good grasp between red blood cells and white blood cells, because here we have them in the millions, and in our white blood cells we have them in the thousands. Again, I'll get to this point when we get to production, but there will always be a slight difference between males and females. Females will always have a lower amount of red blood cells and any indices, anything that has to do with red blood cells, than men. And you know, you see the millimeters cubed. That's the same as a microliter, and I told you before that in one drop of blood you have about 50 microliters. Okay, to give you an idea of volume. So it's a fairly extensive amount of red blood cells that we have in our body. Now, when we talk about the lens of the eye, we talked about it being biconvex. A red blood cell, an erythrocyte, is biconcave. So it looks like almost a filled-in donut. Again, I'll show you a picture so you don't have to suffer through these drawings. But if you think of a lifesaver that's somewhat filled in, not completely, because if it was completely filled in, then it would be a different type of candy. It goes in and it kind of dips in where you almost put your butt, like an inner tube that is, again, not all the way through. Okay, so when we look at it from your textbook, they'll have two different views. Here, you've got the top view, so you can see the indentation here. Okay, here when we look at a side view, you can see the indentation goes down from that standpoint, and it's on both sides, biconcave. All right. Now, this structure is about 7 to 8 micrometers. To give you an idea, the smallest blood vessel in the body is a capillary. The diameter of a capillary, about 7 to 8 micrometers. Okay? So in big blood vessels, these can just kind of float along with their buddies, or side to side, but when you get down to the small ones, they end up single file, like trains in a train car, or cars in a train car. Okay? Lined up. It's called a rouleau when you see it. I'll try and show you a picture of it today. They are essentially filled with a cytoskeleton, kind of give it its shape. They do not have a nucleus because they do not undergo cellular reproduction. They don't undergo mitosis. For the most part, they're filled with this big giant bag of hemoglobin. Okay? Now, hemoglobin is where oxygen is actually transported the most. Remember that I told you that oxygen was transported in the plasma. Okay, and I said I was going to amend that. And again, this is not a number that you need to know, but when we calculate oxygen, the amount of oxygen, we generally have about 20 grams per deciliter, per 100 mils. Okay? The amount that's actually dissolved in plasma, about 0.5 of that. So almost all of your oxygen is carried on the hemoglobin molecule. Okay? And the hemoglobin molecule has two structures to it. The first one is the globin chains, and there are 4 of them. This is what's referred to as a quaternary structure, because there's 4 things that come together. Okay? There's 2 alphas and there's 2 betas. They do change their chains, and when the chains, when we have substitution, I'm going to talk about a couple of them today, substitutions of amino acids in these proteins, that has the potential of changing the structure of that chain. And if that chain changes structure, it has the potential of no longer being able to carry oxygen. Bless you. So, in the middle of it, we have this heme, and this heme has a porphyrin ring, and it has an iron that sits in the middle of it. That's where oxygen binds. Okay? Now again, to give you a kind of rough idea, in every red blood cell, you have 250 million hemoglobin molecules. If each hemoglobin molecule can bind for oxygen, it means one red blood cell essentially holds 1 billion molecules of oxygen. Now, for those of you who either work pre-hospital or work with patients of some sort, there is a test that's done. It's a test that I'm not really a big fan that everybody does, but we'll talk about that in a second. This is a finger, to make sure we're on the same page. There's a device called an oximeter that can fit over a finger, can fit over an ear, fit on a tongue, fit on a lip. And does is it emits two different wavelengths of light. And again, this is more Jeopardy. You don't have to write this down. And what it does is these two different wavelengths of light are they're wavelengths that correspond to hemoglobin that has oxygen bound to it and hemoglobin that does not have oxygen bound to it. Okay? The terms I want you to be familiar with is if this has 4 oxygen molecules bound to it, it's called oxyhemoglobin. Now your book occasionally, especially when we get into the circulatory system, the vascular system is going to call this oxygen-rich blood. We don't call it oxygen-rich blood. It's called oxyhemoglobin. Okay? Meaning that it has oxygen. If it has less than 4, it's referred to as deoxyhemoglobin. So deoxyhemoglobin is not one where it's completely drained of oxygen. In fact, that doesn't occur very often in the human body. Now, the oxyhemoglobin and the deoxyhemoglobin absorb different wavelengths. So when I emit a light source, it comes out of the oximeter and it goes through, the amount of oxyhemoglobin and the amount of deoxyhemoglobin is going to absorb some of those wavelengths. And then it gets absorbed on this side. What didn't get absorbed by the hemoglobin gets absorbed down here in this other little computer. And then it prints out a number called the saturation of hemoglobin. Okay? The problem with this particular test, one, this is a medical test. This isn't like a blood pressure. And so with this particular test, people do it because there's a box that they have to fill a number in. You can have somebody who's 16 years old, never smoked, comes into the hospital because they have a fractured or a broken arm, and somebody puts an oximeter on. No reason to if they're breathing normally. Not one reason at all. But why do we do it? There's a box. And we like to fill in all the little boxes. The problem is that people don't generally have a full understanding of this. So I can get calls that say, can you come up and take a look at Mrs. Jones, and her saturation is 60%. And you get up there, Mrs. Jones is doing a crossword puzzle. Mrs. Jones would not be doing a crossword puzzle if her saturation was 60%. So when you don't understand how this works, so when I used to teach in the respiratory therapy program, I taught a critical care class, and it was the second term of the second year, and we would be going over this, and students would be throwing a little tantrum about, I don't want to talk about oximetry anymore. You just have to ask them a couple questions, and it shows that they don't understand it. And they do need to be the ones who understand it because they do a lot of this. Okay? If you have somebody who has nail polish on, that will affect the reading. If you have somebody that has acrylic nails, that will affect the reading. If you have somebody who has dyes in their blood, diagnostic dyes that we're using to do things, that affects their blood. It affects the number. By about 3 or 4%. So if I have somebody who says, I want you to titrate your patient's oxygen saturation to 92%, and some of these things are going on, my patient actually might be 88%. That's a huge barrier. We want to always keep people greater than about 90%. There's a small population that we keep a little lower than that, but we'll talk about that in AP3. Probably the biggest one, skin pigmentation. People that are African American, the darker their skin, this gets affected. Most people don't realize that. So this is a medical test, and you should probably always understand why you're doing something, how it's going to be impacted before you start making changes on the patient. So that's why it's a big pet peeve of mine from that standpoint. But it utilizes this great tool because before this came out, before we started using oximeters, if I wanted to find out how much oxygen a patient had in their blood, I had to do what's called an arterial blood gas. So this isn't just a venipuncture. Venipunctures are pretty straightforward. You know, you find the vein, you kind of know where they are, you can feel them. An arterial, you can't see the vessel. You can feel it and kind of start getting an idea about rolling your hand over it and figuring out what it looks like. And they tend to be more innervated, so it's much more painful. So you had to stick a needle in to get the blood to run it in the machine to be able to find out how much oxygen the patient was utilizing. So they work pretty good from that standpoint, but it is based off of this little process here. Now, production. So this is where the words are starting to give you an idea, to put things in perspective. You make about 2 million red blood cells every second, which means what should probably be happening to the other 2 million red blood cells?
Gotta go somewhere.
They got to probably be destroyed. If they don't, then we end up with polycythemia, where we have entirely too much red blood cells, and it makes the blood very sluggish. Remember that we have about 50-55% of fluid in our blood. If I suddenly change that and I make it so that there's a lot more formed elements, less water, it's like sludge moving through. Okay? So we're constantly producing, we're constantly having them destroyed. Now, poiesis, the term poiesis means formation of. So hematopoiesis, another term is called hemopoiesis, is a general term that means blood formation. This is where I was saying that we're going to start making some distinctions based off of white blood cells and red blood cells. So in general, when we just talk about blood, hematopoiesis or hemopoiesis. Now, when I'm talking about red blood cell formation, it's called erythropoiesis. So again, understanding that suffix, that end portion of the word, poiesis, and then slapping on whether it's leukopoiesis, whether it is erythropoiesis, just means the formation. Now, over here I have the hematopoietic stem cell. Okay? Now, a stem cell, for those of you who have heard the term or not heard the term, stem cells are cells that they really don't know what they want to be when they grow up. They have a lot of different choices. Okay, so if I'm a stem cell and I'm standing right here, there's going to be a point to when I differentiate and I come here, I'm going to be a red blood cell. I don't get to go backwards. Okay, it's like having just some really overbearing parents. You're going to med school. You're going to be a doctor. You're going to be an engineer. You're going to be an attorney. So once you make that step, you're on what's referred to as a committed pathway. But until then, I've got the world is my oyster. I can become any blood cell I want. That's what a stem cell is. So these all come from what's referred to as a hemocytoblast, or the hematopoietic stem cell. This is a good term because it tells you that poiesis, hemato, so this is a cell that gives rise to all blood cells. Okay? But it's going to make a committed path so that now we're talking about erythropoiesis. Now, when we talk about erythropoiesis, we've got this pathway here. Now, you do not have to know every cell in this pathway. Okay? What I want you to understand is what is the physiologic mechanism that's occurring as you move through here. Okay? And then I will tell you those cells when I'm done that I want you to be familiar with. Okay? So, here's my hemocytoblast. This is my hematopoietic stem cell, where all blood cells come from. So, based off of chemicals, hormones, this is going to get teased to here. Okay, this is a proerythroblast. This is that, guess what? You're going to be a red blood cell. I don't want to be a red blood cell. You're already on the path. This is where you're going to have to go. Okay? Now, as this process occurs, once we become a proerythroblast, we're going to start manufacturing hemoglobin molecules. Okay, we're going to start collecting iron. And as we start to do that, we move along this pathway, and if you notice, I start to change color. Why? Because I'm increasing the amount of hemoglobin in the cell. What does hemoglobin do? It binds oxygen. When blood has oxygen, it tends to turn red. And that's what it's doing. And we're going to keep churning it out and churning it out. Remember, we have 250 million hemoglobin molecules in one red blood cell. Now, since this cell does not undergo mitosis, how about if we get rid of the nucleus? There's no reason to have it. We get rid of some of the other organelles, because again, really, it's a cell that's just this big, giant bag of hemoglobin molecules. So as it moves through, we're going to get rid of that. And now I have what's referred to as a reticulocyte. This is a baby red blood cell. Now, when you do a hemogram, just a test that we look at different aspects of red blood cells, their size, their number, or when we do a CBC, a complete blood count, where we'll look at the white blood cells and the red blood cells, we're going to see a small portion of these. Generally about 1% of all blood cells, red blood cells, are going to be reticulocytes. That's a good number. That tells me that the body's working correctly. Now, once these get booted out into the blood, it takes about 24 hours for them to become an erythrocyte. Now, every textbook's a little different, and the range is somewhat huge, to be honest with you, when you look at different textbooks. So here, you ignore the 2 for a second, because that's more of a, I'll talk about the 2 in a second. But the average is about 5 days to go through this process. Some textbooks actually put it at 10 to 15 days. Important thing is days. We're not talking about we're starting this process early. So again, since we're making 2 million a day, or 2 million a second, excuse me, you can see that this is just constantly moving along. The 2 is essentially if you're hemorrhaging, if there's disease processes going on that are constantly destroying your red blood cells at a rate faster than what you can produce, then your body's going to kick up into a higher speed, and it will process this much, much quicker. So what I would like you to know, cell-wise, you should know what a hemocytoblast is, because that's the stem cell that these come from. You should know a proerythroblast, because that's the first step in this process. You should know what a reticulocyte is, a baby red blood cell. And then obviously you should know what a erythrocyte is. Process, you should know that once I'm on the committed pathway, that I will then begin to manufacture hemoglobin molecules and start to incorporate iron into the hemoglobin molecules. I start binding oxygen, and then I get rid of my nucleus and my organelles. Now, this process obviously has to have something that allows it to kind of have a feedback mechanism. In other words, there has to be a way of regulating how we're building and manufacturing our red blood cells, so that in healthy individuals it doesn't go out of whack is probably not the most clinical term, but more from a disease state process. Okay? This is pretty much done from a hormonal standpoint. And the hormone is called erythropoietin. Kind of makes sense because the process was what? Erythropoiesis. This is a hormone that's manufactured predominantly by the kidneys. There are some special cells that are present, and their job is to essentially detect levels of oxygen. So, a couple terms I want you to be familiar with. I think I've already talked about one, but hypoxia. This is a term that's very, very misused in medicine, and I'm going to tell you the other term it gets mixed up with. This simply means that I have a low level of oxygen at the tissues. So remember I told you that one of the whole points of having blood is its transport. What does it do? It transports oxygen to the tissues, so that we can make ATP and get more bang for our buck. Because when I do it that way, I can get 32, 34 32 or 36, again, depending on the book, moles of ATP with 1 mole of glucose in the presence of oxygen. Now, the word that it gets mixed up with a lot, hypoxemia. And again, this is why it's important to understand those suffixes. Emia means blood. So that's just a low level of oxygen in the blood. Now, can anybody tell me or hazard a guess as to how I can have a low level of oxygen in the blood but not be hypoxic? Not be in a condition of hypoxia, which is at the tissues.
Circulation's still affected.
Pardon me?
Maybe your circulation's still affected and hypoxic.
Okay, so you're on the right track. A little bit more, though, than just effective.
Working harder.
Working harder. Okay? So one of the things, depending on who your instructor is, whether it's in a nursing program, a respiratory therapy program, or an anatomy class, is we often use the term boxcars of train, and that's going to be our process, and we fill the boxcars up with oxygen, and we send them out. Well, if I have a lower level of oxygen in the boxcars, how about if I send more boxcars to the blood or to the tissue? Therefore, I'm not in a condition of hypoxia, even though I have a low level of oxygen in my blood. Okay? So the two terms get used interchangeably, and they should not. They're vastly different terms. Okay? Sometimes it's just a pet peeve. Other times, it really makes a difference. This is one of those ones that really makes a difference. Okay? So we have cells in the kidney, and their sole job is to detect hypoxia. Okay? They have these cells that are oxygen sensitive, and their whole job is they kick out an enzyme whenever it's called the hypoxia-inducing factor. You don't have to know that. And essentially, that's going to change. It starts to increase when I don't have enough oxygen, because the oxygen's job is to start to break that down. So it starts to go up. So what happens is the cell says, uh-oh, I have a decrease in oxygen, and that's really the take-home message there. You can come in. The decrease in oxygen at the cell is going to cause the cell to produce erythropoietin. And then that's going to go to our areas where we have our red marrow. And remember in A&P1 we talked about the difference in a developing skeleton. Pretty much any place where you have marrow in the bones, you're going to be producing blood cells. As you go through delivery and then the infant starts to go into childhood, we start to decrease the amount of areas. When we get to be adulthood, we're looking predominantly at our regular bones, so our vertebra, our oscoxa, the sternum, the scapula, mostly our regular bones are the ones that produce it. That's one of the reasons why when we get marrow samples, we get them from these particular areas here. Okay, so again, the irregular bones, one of the easiest access ones happens to be the hip bone. Okay, so when you go in, they will drill in different parts to gain access to your marrow. But these are the places that will produce red blood cells. They will respond to erythropoietin, and the production will be stepped up based off of the level of oxygen that's here. Now remember I told you that with all red blood cells, there is going to be a difference between men and women. The primary reason is because testosterone increases the activity of this. And women do not have testosterone, not to any great degree. They do produce an androgen. Androgen is kind of a general term for a hormone that's similar to testosterone, but they do not produce it to a great degree. And the fact that women have a menstrual cycle, and so once a month there is a shedding of the endometrial tissue, which includes blood, and therefore you do have a decrease in the amount of blood that's there. It's not a large amount, but still the most important factor is going to be the testosterone that's present there. Now when we make hemoglobin, which goes into the red blood cells. It's like making a sandwich. Okay, so if you're going to make a bologna sandwich, and it's 2 slices of bread and 1 slice of bologna, and I've got 10 slices of bread and 8 bologna, how many sandwiches can I make? 5. Doesn't matter if I've got more bologna, I don't have enough bread. So we have to have things coming together to be able to manufacture this. Okay? Iron, which is going to go into the porphyrin ring, which is going to make the heme. And then we have to have our globin, our amino acids, which go into making the other process from that standpoint, the chains themselves. Now, iron is very, very toxic to the body. It cannot exist in its free form just floating around. Okay? It is very, very damaging to our vasculature, to our blood vessels. So it always has to be paired up with something. So it's either going to be in the hemoglobin molecule, but when it's not, because we're still manufacturing, remember we're kicking these things out, 2 million every second, it has these 2 carriers, ferritin and hemosiderin. Now, when I need to put iron into a hemoglobin molecule, so I have to get it to where the manufacturing is going to take place, then it travels along transferrin. So these are all 3 protein carriers that essentially bind to iron. And when iron's bound, then it's not going to have its negative effects on the vasculature, on the blood vessels. Now we have to have B12, one of our primary B vitamins, folic acid. When we don't have enough of these 2 things, we don't have good DNA replication, and we end up with red blood cells that are either small, or if they're large enough, they don't have all the quality, so they can't carry oxygen. The other thing that we're going to need, and I'm going to talk about this when we get into a discussion called anemia, is intrinsic factor. Intrinsic factor comes from cells in your stomach. And what intrinsic factor does, it allows for you to absorb vitamin B12. So when you, we'll get into this a lot in AMP3, but essentially your digestive tract is one big tube. Starts at your mouth, goes to your anus. Okay? We put stuff in, hamburger, shake, fries, and then we break those down into the smaller components. So right now we'll just leave it nice and easy as our fats, we'll leave it as our carbohydrates, our proteins, our vitamins, and our minerals, and then they get absorbed out of the GI tract into the blood so the body can use them. What doesn't get absorbed continues down the process and will end up in the toilet. But that's all the digestive system is, one big giant tube. We just change the environment on the inside of the tube so that this process can occur. We can break them down, we can mechanically digest, chemically digest, then we have absorption. So I can have all the B12 that I want in here. If I am lacking intrinsic factor, then B12 cannot make its way out. If it can't get out of the GI tract, it can't get in the blood. If it can't get in the blood, I might as well have not eaten B12. This is the whole point of Olestra, by the way. So those of you who've ever heard of Olestra, which was a diet supplement that basically prevented you from absorbing fat. So you could eat all the fat you want, but if it didn't get absorbed, then you're not going to increase the calories. Okay? If you ever watch the commercials, it would tell you that you have anal leakage and explosive diarrhea. Because all the fat stays in here and it goes through you like, you know what, through a Christmas goose. So you might be nice and svelte, but you can't leave the house because you're ruining your pants. The reason why you don't really find Olestra on the market anymore. Because people are like, this isn't fun. So I'm producing it, or are regulating it, we're going to destroy it. Okay? Red blood cells, think of them as being like human beings. Okay? You're 16 to 22, you can bend over, you can do the splits, you can do all sorts of things, and as you start to get older, your body's just like, oh, Lord, I can't do that anymore. Okay? Same with these things. That cytoskeleton I told you that was essentially in a red blood cell, so when you start to go through these little tiny capillaries, remember they're about the same size as they are. They can kind of, you know, move their shoulder over here so they can swing by. Eventually, that cytoskeleton doesn't allow them to do that. And so they're going through this tiny little capillary and they're just like, oh, I shouldn't have had that hamburger. And now they're stuck. And then we have these macrophages that go into the blood cell, or into the blood vessel, excuse me, the capillary, and essentially tear it apart. Body's very sustainable. We try and reuse things. So as we go through this process, here we have up at the top where we're low oxygen in the kidneys, produces erythropoietin. We have our increase in the amount of blood cells from the red marrow. We start to go through, and after about 4 months, 120 days, we break them down. So here's my hemoglobin, heme and globin. The heme is my iron. Here it's going to get stored as ferritin and hemosiderin. Again, this is a great slide. Tells you an awful lot of stuff. Print this off, look at it 4 or 5 times a day, and you're going to have it all down. The globin is made up of amino acids. It's protein. We're going to reuse our amino acids. My iron will then get stored. A lot of it is stored in the liver itself for a couple reasons. One, we utilize it to make a, it's not an enzyme, it's an emulsifier called bile. Bile is a very important thing for digesting fat. Facilitates the digestion of fat. So that's manufactured here, and then I'm going to use my ferritin and hemosiderin, but when I want to start making my red blood cells, I'm going to have to move that iron to the appropriate location, and it has to go on that transferrin. And again, start thinking of ways to remember that. Transport, transferrin. You see the F-E-R-R, that's one of the key prefixes for iron. Okay? So we're going to take it and make more. Now the bilirubin, we're going to use and put it in bile. It's going to go into our small intestine so we can absorb some of these things and we can break things down, specifically fat. We're going to reuse some of that. What doesn't get used gets broken down farther, and it will make a thing called stercobilin. This is what gives your feces the brown color. So individuals that have liver problems, or we're not storing our liver, or the liver's down, or it doesn't make bile, end up with feces that has a green-grayish color to it. So again, one stool where it's green-gray does not mean you have liver cancer and you're going to die. But if it looks like you've got this process going on for quite a while where your feces is not a brown color, you might want to have your liver enzymes looked at. Now, I will tell you from the standpoint of that 120 days, because again, it's just a cell that is filled with this bag of stuff. We now have been able to utilize the physiology of a red blood cell, because all they really do is they kind of absorb some things from their environment. So if I was questioning whether I thought that you had diabetes or not, we would do a fasting blood test on you. So we would make sure that you didn't have anything the night before. You come in and I would see what your blood sugar is in the morning. Then we could do some challenges and so forth. Well, instead of doing that, we now do a hemoglobin A1C. It's called a glycosylated hemoglobin because these are around for 120 days. So when I look at the A1C, the hemoglobin A1C, if it's greater than about 6 to 7, then it means you probably have had a very, very elevated blood glucose for a prolonged period of time. So it's more of an accurate reflection of a diagnosis of whether you potentially have diabetes or not, or at least pre-diabetic. So, and then the goal would obviously be to try and get that number down below those values. So knowing that that hemoglobin, the red blood cells are around for 120 days, we can measure the amount of sugar in there. That's what the glycosylated hemoglobin is, and it'll give us an indication of that. Any questions on that? Some of the problems, probably the biggest one that you might have heard is just anemia. Anemia is just a general term for a decrease in oxygen carrying capacity in the blood. It could be that I have too few hemoglobin molecules. It means I could have too few red blood cells as a whole. So we kind of classify our anemias. The first one is one of the more obvious ones, hemorrhagic. Our red blood cells have to stay in the blood vessel. That's going to be a big distinction between our red blood vessels and our white blood vessels. White blood cells leave the blood vessel. That's one of their functions. They're part of the immune system. Red blood cells, we don't want them leaving. So if I have a cut in my arm, if I was involved in a fairly significant trauma, so keep in mind that you have 5 to 6 liters of blood, correct? So if I fracture a femur, I could lose probably 1 to 1.5 liters. So if you have bilateral femur fractures, you're involved in a head-on collision. So a car hits another car hits telephone pole, you move forward. If you're wearing your seatbelt, it's very easy to take the heads off of your femur. You could also end up with a pelvic fracture. So you could actually bleed to death with what would be considered non-life-threatening, but that's why it is life-threatening. So when we have a high incidence or a trauma activation would be a high-velocity crash because there's a lot of damage that can come from that. Okay? So lots of blood can be lost when it's not in the blood vessel anymore. We can have hemolytic. Now we'll talk about this probably tomorrow, but hemolytic, hemo means what? Blood. Lytic means to break down, to destroy. So anytime you hear the word lytic or lysis, if you have cellular lysis, it means I'm breaking the cell open. So I'm destroying it. Now there can be drugs that do that, immune responses that do that. Those are probably the 2 big ones. Now I can have aplastic anemia. Now aplastic anemia is actually fairly, it's pretty much the most evil, I guess, if you want to apply those kind of terms to the body. So here I would be essentially breaking down the roads that your soldiers are on. Here I'm killing the soldiers. Here I'm killing your elementary school so you can't make any more soldiers. So aplastic anemia is where you have a destruction of the red marrow. The place that manufactures your red blood cells, that is what is being destroyed. And again, chemical, radiation, cancers, those are probably the 3 biggest things that will cause aplastic anemia. Now I'm going to put these 2 things together, but I want you to understand the distinction. Yes, ma'am?
What did you say causes hemorrhagic?
Trauma, gunshot, stabbing, hammer. So pernicious and nutritional both have to do with stuff we put in our body. Okay, but I'm going to tell you the distinction. So remember we talked about the necessity to have B12 and folic acid. Okay? So nutritional anemia is I just have a crappy diet. Instead of this, I might have Snickers bars all day long. Okay? I'm not putting good things in my body. I'm not putting enough B12 or folic acid in my body. That's a nutritional anemia. I can fix that. How do I fix it? I can eat better. Pernicious anemia is where I don't have intrinsic factor. So I can have the best diet in the world, but because I don't have that hormone that comes from the stomach that helps me to absorb my B12, I can eat all the B12 and folic acid I want, but if I don't get my B12 from the inside of here to the blood, then it's referred to as pernicious anemia. So again, if you're taking care of a patient that has stomach cancer, had their stomach removed for some other process, or a very, very, very nasty gastric ulcer, then you definitely might want to be thinking, my patient could potentially be anemic. Why? They're not getting the B12. Any questions on that? The last few, these two things here, thalassemia and sickle cell, this is where we actually do something to the chain itself. Thalassemia comes from people that are of the, what are referred to as the Ashkenazi Jews, Middle Eastern descent. So it's a genetic component. They're actually missing one of their chains. So that's where they have a decrease in oxygen carrying capacity. Probably the one that most people are familiar with is sickle cell. And sickle cell is one of these things. It's a mutation that occurs in the chain itself. So here it's just a simple substitution of one amino acid. Sometimes one substitution is not a problem. It depends on the location of the protein. Here it is. This is one where that simple change causes this red blood cell in the presence of low oxygen to sickle. And these get caught. They dam up. They get very, very sharp. So I end up with pain because they can stick into the blood cell itself, but they can also back up blood, which means any blood that's distal, any area that's distal is not getting any blood, and therefore you have pain from that standpoint. Now it can be just in the legs, it can be in the arms, but when it gets into the chest, they have what's referred to as chest syndrome, you can actually die from this. So IV fluids, blood transfusions, pain medications, oxygen obviously. There's another one called, we can administer a drug called hydroxyurea, and what it does is it converts one of these chains back into a fetal hemoglobin. And fetal hemoglobin does not carry oxygen as well, but it doesn't sickle. Now, it's a mutation, and the reason why we tend to see it predominantly in African Americans is because it was a genetic mutation that conferred protection from malaria. So while you were protected from malaria, you were also at a higher risk for developing sickle cell. And just as a side note, this is a recessive trait. So both parents have to have the recessive component. But what's interesting about this so no sickle cell, recessive trait, disease. So every child that's born has a 25% chance of developing or contracting the disease. Okay? Now this is where it's a little weird. In most of these two are considered carriers. In almost every other recessive component, the carriers do not demonstrate any part of the disease at all. In sickle cell, they have a very, very mild symptom. So this person has the full-blown disease. These two being carriers just have a mild component, but it is something different. If this was cystic fibrosis, the numbers are exactly the same because it's a recessive trait. The difference is that the carriers they don't carry any symptoms at all. Okay? And then the last one before we go on a break is, I put this on there just because you hear about it a lot, predominantly with cycling. Cycling just tends to be one of the endurance events where there seems to be a lot of cheating. Okay? So what people would do is they would either they would go months before their event and they would donate their own blood. In other words, they would take blood out of their body and they would store it. So then before the event, they would give that blood back to themselves. Therefore, they would have more hemoglobin molecules. If I have more hemoglobin molecules, I carry more oxygen. If I carry more oxygen, I'm going to do better. Problem is that stored blood and blood that exists in your body have different enzymes. So that was a way that they can do that. And even before they did their own, they used to just take somebody else's blood. Now, if I give you more blood, does that not change my ratio of fluid to formed elements? So what does that do to the viscosity, the thickness of the blood that you have? It makes it thicker. What do you suppose that does to your heart? It makes it harder to pump the blood round and round. Okay? This is one of the reasons why, just again as a quick side note, for people that do things not cheating wise. So if you're going to go to Mexico City, you're going to go to Boulder, Colorado, you're going to go to what's referred to as elevation. Okay? So if oxygen here in Eugene is 21% of the environment, what's the percentage of oxygen at Mexico City, which is what's referred to as that elevation? Is it higher or lower?
Lower.
Okay, it's the same. Now, the amount of oxygen is lower. The percentage in our environment is always the same. It's the pressure. So to find out how much oxygen you have, you multiply this times your atmospheric pressure. Here we're at 760, here we might be at 713. So when you multiply that, the level of oxygen is lower. This is one of those old exercise physiology trick questions that dicks like me always throw out there. So the percentage is the same, the amount's lower. So what happens? I'm hypoxic. So what does my body do? But what's the compensatory mechanism? What are my kidneys going to do? They're going to be hypoxic, so they're going to make more red blood cells. This is the problem, though. If I go to altitude and I'm used to running at a certain speed, down here where I have plenty of oxygen, I go to altitude, am I going to be able to train at the same level that I was able to train for here? No. So one of the tricks now from an exercise standpoint is you live at altitude, you train at sea level. Because as you're living up there, you're kicking back in your lounge chair, you're doing all these things, you're getting the benefit of living in a hypoxic environment, but then you go and you train where there's plenty of oxygen. It's hard to do because it's hard to make that transition from high to low. They have tents that you can live in, they're hypoxic tents, so that when you go to bed at night, you decrease the amount of oxygen and it's going to be the same type of a thing. You know, just things that people do. You know, the Olympians didn't do this, so the Olympians a long, long time ago.
Is that why people use hyperbaric chambers?
No, hyperbaric chamber is the opposite.
Oh.
Hyperbaric chamber is where I take, so if this is 1 atmosphere, so in my plasma I might have 150 millimeters of mercury for my blood. I can take this to 3 or 4 atmospheres. And I can increase the amount of blood carrying capacity because it increases the plasma. So that's what we do for patients that have things like gangrene. They have infections that are anaerobic. So the bugs are anaerobic, they don't like oxygen, so what am I going to do? I'm going to stick them in a chamber and I'm going to give them as much oxygen as possible and kill them. Or you can be Michael Jackson and think it's going to make you look younger. But there's really no belief in that at all. So any questions on this poked part? All right, why don't we take a break, we'll come back, we're going to do the white blood cells, and that's what we'll end today, and then tomorrow will be blood clotting and our blood. So we undergo what's referred to as the amoeboid action. Now, probably the best description of amoeboid action, if you've ever seen anything about the way that the pyramids were built, big giant blocks of stone, people obviously didn't carry them. So you could have logs that were underneath. And as you moved along, one of them popped out, they picked the log up, they brought it back and put it on the front. It's almost exactly how cells undergo amoeboid action. They use calcium and they have these foot processes that actually come out of the cell. And then as you get down towards here, they're brought back into the cell. Either broken down and reutilized or put back up. But that way this thing has the ability of rolling along, and when we get to the immune system we'll talk about how they know where to go, which is chemotaxis. But those are the 3 primary distinctions between red blood cells and white blood cells. The number, diapedesis, and amoeboid action. Bless you. Now, we have 5 of these. Okay? Your book has a really good mnemonic to remember the 5. And not only are you remembering the 5, but you're also remembering them in the order of their abundance. Okay? Never let monkeys eat bananas. Okay? So neutrophils, lymphocytes. Again, this is one of those areas I might put a little asterisk by lymphocytes because students often confuse leukocytes and lymphocytes. Okay? A lymphocyte is a leukocyte. Not all leukocytes are lymphocytes. Leukocytes are a general term for white blood cell. Okay? Monocyte, eosinophils, basophils. So obviously most abundant, least abundant. Now in your book there's a table, they're going to tell you what the percentage is. I am in no way, shape, or form going to ask you what the percentages of these things are. I do anticipate you're able to tell me that there are more monocytes than there are basophils. Why? Because never let monkeys eat bananas. It's going to allow you to memorize the 5, but it's also going to allow you to understand the order in which they're done. Now, we break these things down, by the way. We break these things down by how they stain. So when we look at slides, we put different dyes in there. And based off of the quality of that cell, it's going to absorb dyes that are basic, dyes that are acidic, and it gives us these different colors. Okay? Not only does it give us our colors, but allows us to see inside the cytoplasm. Remember, the cytoplasm is the liquid part of the cell. And in some of these, we see little tiny rocks, little granules. Okay? That's why they're referred to as granulocytes. So this is great because it's going to tell you all 5. The problem is it doesn't tell you which ones are granulocytes and which ones are agranulocytes. Okay? That one you're going to have to do on your own because you do have to be able to tell me the difference. Now, probably the biggest of the granulocytes, there are 3 of them, are going to be the neutrophils. Now the neutrophils have this ability to undergo phagocytosis. And again, phagocytosis is cellular ingestion. And it doesn't have to be just a pathogen. There's a variety of things that a cell can phagocytize. But it just simply means I'm able to engulf it, I break it down, I make it so it's not dangerous anymore, and then we spit it out the other side. Okay? Now, this particular one we see with our bacterial infections. Okay? This is one of the ways that a physician or a healthcare provider is able to kind of have a rough idea of what's going on with you. Okay? So when you go to the physician, when you go to your nurse practitioner, your PA, and they do some blood work on you, they're able to look at, if they do a CBC, they're able to look and say, well, you probably have a bacterial infection. Why? Because my neutrophils are elevated. So we have the big number here, which is all of our white blood cells, but I can do a differential where I can say, my white blood cell count was up. Which one is up? And neutrophils generally will knock them up. Why? Because they make up the most. I can have an increase in my basophils, and it might not increase my total number of white blood cells. But when I do a differential, I notice that these are up. So here we see them in our bacterial infection. Now when we look at these under a microscope, it also tends to lend itself to its other name. Okay, PMN leukocytes, which is a polymorphonuclear leukocyte. Okay, long name, but when you break it down, it makes it very simple. Poly means many. Okay, morpho means shape, nuclear means nucleus. So it looks like it's got more than one nucleus. But it's not. It's one nucleus. Now, I will tell you that depending on, again, the textbook, depending on the person who's writing it, some people will say all granulocytes are considered PMNs, polymorphonuclear leukocytes. Others say it's just the neutrophils. Now, this has what's referred to as a segmented shape because the nucleus is turned into segments. Okay? So when you look at this last bullet here, before I take you out this picture, can you see the granulocytes? That's how we know that it's a granulocyte. it's got what looks like little rocks and pebbles in it. Okay? Now, where you see the bands and the segs, a immature neutrophil, their nucleus doesn't look like what I just showed you. Instead of segments, it looks like it's maybe wearing one belt really tight and it's banded. Okay? So when we look at these things under a microscope, or if it's doing automated, so sometimes you'll see that it was a manual differential, which means somebody actually had to just sit there and go click, 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 click. So they're looking at this one particular slide as opposed to running it through a machine that does it automatically. So if somebody asks for a manual differential, they actually have to go through and count them by hand, which is the way we used to do it. You know, it's kind of like the old days when you watch the checkers, they could punch in the numbers of everything, as opposed to the ones that just like beep, beep. Okay. So if I have more bands than segs, we have what's referred to as a left shift. And so you'll see that on reports sometimes. And what that means, it's a pretty significant infection. Because I am having to send out, instead of my soldiers, and again, I'm sorry if you're a pacifist, but war is generally, battles are kind of how we describe our immune system, because that's exactly what's happening, okay? So the segments are my soldiers that I'm sending out. So if we're in a battle, and the battle is continuing to go on, and I'm running out of soldiers, then I'm going to have to start sending out my junior high and my high school kids to fight. So bands are immature. So if I see bands, it means that this is a significant infection. And the left shift is classified as numbers 1 through 4. 4 being, if you have a fourth shift, it's a pretty significant infection. Now the other thing that this has the potential of occurring, and I'll talk about it again when we get into the immune system, is a thing called a respiratory burst. So occasionally granulocytes, but neutrophils specifically, have this ability to manufacture a bleach or a hydrogen peroxide-like solution. And it's extra killing. Okay? So think about, sometimes the cell dies. So think about if you're a good guy and you're walking in and you're going to just detonate yourself to kill all the bad guys in one foul swoop. That's what a respiratory burst is. It takes oxygen. We use oxygen radicals, superoxides, and that's how we manufacture the respiratory burst. Now the next one is called eosinophils. Okay, this is the second of the granulocytes. Okay? Now eosinophils, again, this is just the order that all leukocytes occur in. This has nothing to do with whether they're granulocytes or agranulocytes. What I'm talking about over here is how we classify them, whether they're granulocytes or not. So eosinophils, when we look at them, they generally stain red. They've got what's referred to as a bilobed nucleus. You can see the little rocks in there. Those are my granules. Now, you want to be thinking of the W's when you think about eosinophils. Okay? We see eosinophils in allergic reactions. Okay? Does anybody know what happens to your airways in allergic reactions?
Close it up.
They close up, so does anybody know what sound that makes? Wheezing. You wheeze. There's a W. Wheezing eosinophils. So if I think you're having an allergic reaction and we do a blood test, I might see your eosinophils being elevated. The other place we see them? With parasitic pathogens, worms, flatworms, roundworms. So if you have those that have invaded your body, whether it's poor hygiene, whether you drank bad, you were in an area, then you drank filthy water where animals had gone to the bathroom and that type of thing, good way to get parasites. So worms. And then the last one is weird. Okay? So hopefully one of the things that you will eventually do as you move through your healthcare careers, you will stop watching House and ER and Grey's Anatomy because they're just crap. They have no basis in real TV whatsoever, real medicine whatsoever. I unfortunately, having both my parents in the medical field growing up, we kind of had that drilled into us very, very early. That would never happen. That's just wrong. So they're just crappy shows. But House is one of those shows where you have the weird. It was always something bizarre. It was never the person came in and they had a brain tumor and we fixed the brain tumor. It was always something that they ate or some genetic process, some metabolic pathway that was screwed up. Weird. Things that you have to be in the darkest part of Africa every 10 years at midnight on New Year's Eve. That's the only time you can actually contract this disease. Okay? So it's the weird stuff. Those are the three things you should always think about with the eosinophils. All right? And then the last one are your basophils. Now your basophils, it's hard to see from where you're at, but their nucleus almost looks like a swan. Okay? And again, it is a different shape, and that's the reason why some authors will call all granulocytes polymorphonuclear leukocytes. Some, again, just call it a neutrophil that. But it stains generally a very dark color. The nucleus is usually a purple color. Their granules are a little bit larger, because these granules are actually filled with things. They're not just little rocks. That's the description. The granules are filled with chemicals. And basophils act like a cell called a mast cell. And mast cells are ones that have histamine in them. So when you're allergic to things, this releases histamine, and histamine causes this massive cascade effect of this causes this to be released, this causes this to be released, this causes this to be released. But one of the big things is histamine. Okay? Heparin is another one. Basophils are the same one, just a different cell. A mast cell is part of the immune system, but it's not a white blood cell. A basophil acts just like a mast cell, but it is a white blood cell. And again, in the grand scheme of things, it's the least common of all of them. Now, when we look at the other group, which are the agranulocytes. So when we look at these things under a microscope, we hope to see a smooth cytoplasm, because they don't have these little rocks in there that are filled with chemicals. Okay, and we have two types. So the first one are the lymphocytes. Now remember, I told you, this is where students have difficulty because things sound the same. A lymphocyte is a leukocyte. Not all leukocytes are lymphocytes. And I don't mean to beat that into the ground, but just to make sure everybody understands. A leukocyte, you could be a neutrophil. You could be a monocyte. You could be an eosinophil. So this is always a leukocyte, but not all leukocytes are only lymphocytes. So I would make that point in your notes. Now, these things are divided into two groups. We have T lymphocytes and B lymphocytes. And again, we'll spend a lot of time with these particular cells in the immune system because they have a different task. These make antibodies, B lymphocytes, and T lymphocytes run the show. And they handle both viral infections and bacterial infections. And they just kind of hang out here in the lymph, waiting for pathogens to come by, because that's one of the areas pathogens will be. Remember, pathogens are just cells that are, or pathogens are just microorganisms that have the ability of causing disease. Okay? Now, when we look at them, this is a lymphocyte. They're almost all nucleus. They're a tiny cell, all nucleus, but if you notice their cytoplasm, no granules. Hence the term agranules or agranulocytes. The last one are called monocytes. Okay, monocytes basically become huge macrophages. What's a macrophage? Cells that undergo phagocytosis, cells that eat things. Okay? Now, I don't mean, again, to be sexist here, but if you are part of a high school or a college sports team and you're on a road trip, So you have your football players and you have your rally squad, all right? And then you go to the buffet, and the rally is going to say, "Just go salad." The football players are going to decimate the buffet, okay? The neutrophils are the rally squad. The monocytes are the football players. These things will eat and eat and eat and eat. They last for a long time, okay? A neutrophil probably lasts for 10 days. And they don't eat that much. So even though they undergo phagocytosis, they pale in comparison to this. So if we even wanted to do a non-sexist thing, this guy would be the guy who ate all the hot dogs at the hot dog eating contest on the 4th of July, and these would be the rest of us. You know, 1 or 2 Hebrew nationals, perfect. I don't need 65 of them stuck in my gut. Yes, ma'am.
So the neutrophils and the monocytes are the only two that go through phagocytosis.
And these things just eat anything. Viruses, bacteria, TB is a bacteria, parasites, those are our worms, our helminths, there's a lot of different things that kind of fit in that category. Now, as with everything, we have to have regulation, because these things have to be stimulated. This is a little bit more complicated than blood cells, than red blood cells. Okay? And I don't need you to get into these into the weeds, the nitty-gritty of it. But there are a couple things you need to know. So we have things called interleukins. Now, one of the things you're going to hear a lot, specifically when we get into the immune system, is a type of cell called a cytokine. It's not really a cell, it's a chemical that's released. Okay? And what cytokines do is they act like hormones, except they're actually produced, and it's their cause of release, which is the reason they're not hormones. They have similar qualities in hormones. But cytokines basically affect other cells that increase your immune response. That's what a cytokine does. An example of a cytokine, your interleukins. Please do not get lost in these numbers. I am in no way, shape, or form going to ask you which interleukins are necessary. Okay? But you should know that interleukins are a cytokine, and they help to stimulate the activity of white blood cells. The other one are colony-stimulating factors. So this is how they know to produce more neutrophils. This is how the body knows when to produce more basophils, more eosinophils, more lymphocytes. Colony being the specific word there. If you think of each of them as a colony, then when a chemical is released, when a colony-stimulating factor is released, it's a colony-stimulating factor for neutrophils. It's a colony-stimulating factor for eosinophils. Now, where do they all come from? This picture here. So if you look at the very top, that cell should look familiar because we've talked about it in red blood cells. This is my hematopoietic stem cell, my hemocytoblast. All blood cells come from a hemocytoblast. But then we have to take that committed step. So remember, in the previous one, we took the committed step, and that took me to a proerythroblast. And no matter what, I'm on the pathway to become a red blood cell. I don't get to be a white blood cell. Okay? So here we have 2 branches to become white blood cells. Our committed steps. So we're going to come down here, and I'm going to have what's referred to as a myeloid stem cell. Still not completely committed because I have more than one type of white blood cell I can become. Now over here, I'm committed pretty much right off the bat. If I'm a lymphoid stem cell, I'm going to become a lymphoblast. And my option is lymphocyte. Either a T lymphocyte or a B lymphocyte. The rest of them come from over here. Now, you are not going to, in any way, shape, or form, have to walk down every cell on this slide. Again, as I stated before, you should know what a hemocytoblast is, because that's where all cells come from. You should probably also have an idea of its other name, the hematopoietic stem cell. They are one and the same. But here, my myeloid stem cell can become an eosinophil, a basophil, a neutrophil, or a monocyte. Now, when you memorize memorize things, memorize smartly. As long as you know what all of these are, in other words, all of your possibilities are the neutrophils, the lymphocytes, the monocytes, the eosinophils, the basophils. Well, the lymphocytes come from a lymphoid stem cell, which means the rest of them come from the other. Saves on having to memorize a ton of stuff. It's just like if you know one option is up, do you have to memorize the other option is down? No, it's the opposite. This causes it to go up. I wonder what this causes. It must cause it to go down. Do I have to memorize it? Nope. Now, some of the problems with this. So I already talked about leukocytosis being an excess of white blood cells, leukopenia having to be a decrease in white blood cells. Penia again means poor. Probably the biggest one are the leukemias. And I used to spend a lot of time going over the leukemias. I was teaching a pediatric advanced life support class at OHSU, and I was talking to a hemom, that's their hematology oncology specialist, and I was asking them how they would recommend, this basically being taught, especially at this particular level. Because when you read through some of the stuff, they make it sound like, this hits this group of people, this hits this group of people. So I'm going to kind of just basically give you the names of it and why the names come about, and that's the depth that I really want you to know. I don't need you to get into the weeds on it. So the first thing that we're going to do is we're going to talk about whether this is acute or chronic. Okay? And it has to do with these cells here. So if it's these cells that are growing, so by the way, leukemia is a cancer, if I didn't state that. So when we talk about cells growing too fast, cancer. So acute, usually it's one of these that's growing too fast. Chronic, it's one of the cells down here. Chronic also tends to allow for a little bit longer life. Acute does not. I worked with a rehab nurse at Sacred Heart before it went over to Riverbend. Happened to be looking in the paper and noticed his obituary was there, and he read through it, and he and his partner had gone down to Mexico, and everything was fine. Came back, he was dead a week later. He had an overwhelming acute lymphocytic leukemia that killed him in a month or a weekend. So acutes generally are very, very rapid. Maybe not a week, but pretty quick. And the chronics again are down here. So the next thing that we look at is, did it come from this, or did it come from this? So if it's in this tree here, it's referred to as myelocytic. If it's referred to this tree here, it's lymphocytic. So when we put them all together, you have 4 options. And again, we get very lazy. So ALL, CLL, AML, and CML. And that's sometimes how those people that specialize specifically in oncology would probably give report. Patients here have ALL, instead of going out through the whole acute lymphocytic leukemia. So what you should be able to tell me on an exam is, how do you derive, if I ask you, how do you derive chronic lymphocytic leukemia? You should be able to tell me it's coming from cells that are farther down the pathway, and it's on the lymphocytic side. Okay? Meaning that it's probably this cell right here. If it was acute lymphocytic leukemia, then it's probably this cell here. It's earlier in the differentiation process, and it's along the lymphocytic pathway. The myelocytics, pathway area. Chronics, more than likely these cells. Acute, more than likely those cells.
I thought that you had said that acute would cause you to not live as long as chronic, and so I thought that acute would,
Kill you faster.
yeah. And so I was wondering why chronic wouldn't kill you faster, because,
It's not, you're not growing out of, the pace in which the cells differentiate is not as fast. And it doesn't cause as much problem. Because these are leading to all of them. So this is going to be a more widespread process. More widespread means that you're going to have a harder time trying to find it.
okay.
And again, I wouldn't get too lost in it because again, there are so many other, that's why the hemoncs, the hematology oncology physicians at OHSU were like, yeah, I probably wouldn't teach it that way because there are different cells that are involved and it just, you really, that's why you have a, here we just kind of call them oncologists, okay? So, if you've been exposed, have been unfortunate enough to have been exposed to yourself having cancer, a family member having cancer, in Eugene, Oregon, even our oncologists are hematologists. We generally just don't refer to them that way, whereas at big medical institutions, they're called hematology oncology residents, and that's why they just shorten and call them hemoncs, because it has both. So they're handling both red blood cell problems as well as white blood cell problems, which are cancers, that type of thing. So there's a lot that goes into it. Any question, yes ma'am?
So if someone has a stem cell transplant, are they basically just wiping out all of the cells and starting fresh with someone else's?
Yep. So you go into an isolation, and we basically deaden you up, which is one of the reasons why you're in isolation, so that you don't catch anything. Because we're going to lower your immune system down dramatically, and then you would then get hopefully stem cells from somebody with a good match. And that will repopulate it, and then you'll be able to fight the cancers and so forth. So the last part of this is our platelets. Okay? And again, the other name for platelets that you do need to be familiar with are thrombocytes. Now, these come from a cell called a megakaryocyte. Anybody want to hazard a guess as to where a megakaryocyte comes from? How about a hemocytoblast? All blood cells come from the hemocytoblast. Now, this structure, so probably one of the best descriptions, and you're not going to see this very much, and it really has nothing to do, it has more to do with age, but so when people really did send letters and you had to have stamps for your letters, you would get a sheet of stamps. You could get a roll of stamps, but you could also get a sheet of stamps. And they're perforated, so you can obviously rip off one stamp at a time. This is a sheet of stamps. The platelets are each individual stamp that comes from the sheet of stamps. Okay? These things basically are part of, we're going to talk a lot about them tomorrow, they're part of the clotting process, hemostasis. So if I have too many of them, and again the numbers are vastly different than what you've seen before, they're not as plentiful as red blood cells, but they're far more plentiful than white blood cells. So we have 150 to 300,000, and again some textbooks actually put it at 400,000. So again, it's always important to know what lab you're working with, and you never really have to remember all of them, because if you've never been in a hospital, when you get labs, they basically have the value that was reported and the range, highs and lows. And not only that, they usually put a big giant H by the value if it's high. So you don't even really have to look over, oh, this seems to be high. Yep, it's high. So they kind of take the guesswork out of it. So if you have something that's down here, again, think of your words, thrombocytopenia. So penia means poor. This was just here to remind me, so don't think that this because it's on this side, and I know that's confusing, so that might be my fault. But this is thrombocytopenia if you're less than the lower value. Penia means poor. If I'm on this side, it's thrombocytosis. So just the same type of words that we used with our leukocytes. What do we use to regulate it? Another easy poietin. thrombopoietin. Yes, sir.
The 150 to 300, that's total, like in your whole body, or
No, pretty much the same for the millimeters.
for the micrometer? Okay.
Now, if I don't have very many, I bleed. You bleed and bleed and bleed and bleed and bleed because you don't have the ability of stopping the process. Okay, this forms what's referred to as a platelet plug, which we'll talk about a lot tomorrow. If I have too many, then I just clot. Okay? One of the things that you might So this is a kid that is not burnt. This is a kid that has, and I talk about this a lot when I teach pediatric advanced life support because we live in an area, the Pacific Northwest, is a much higher incidence of contracting this particular bacteria, Neisseria meningitidis, and it causes meningitis. And meningitis in and of itself is an inflammation of the meninges, and not a great thing to have, but usually if you end up getting that, you don't end up getting this. This is a systemic infection. So this is referred to as meningococcemia. And this is one where I've used up all my platelets. So we start to bleed. And so this is actually just blood that's present there. The survival rate for people that get this, so you guys, if you've lived in this area for a while, so probably the last 3 or 4 years we've had some outbreaks on campus at the University of Oregon. There is a vaccine that you can get. But this can happen, just to give you an idea, within a day. Some of the other ones that you might see. So these little dots here, the small ones are referred to as the petechiae, and the big ones are referred to as purpura. They're non-blanching, so when you put your finger on there, it doesn't cause the blood to go out. So I had a 1-month-old that came into the emergency department. Dad put the kid down after lunch, went and woke him up an hour later. And the kid was actually covered by it. This isn't the kid, but was actually covered by it. Surprised that that kid survived. But the survival rate for these is basically about 50%, depending on when you get them. And you die quickly. One of the big lawsuits that Sacred Heart lost, before they moved over to Riverbend, they had a girl who was in the emergency department. They kept her there most of the day. She was admitted to the intensive care unit at 10 at night. I went home at 1. She died at 2. And she should have never been kept in the emergency department for that long, which is the reason why Sacred Heart lost their lawsuit. So that's just a different, kind of a smaller picture of the purpura. So whenever you see these, you always want to make sure you put a mask on immediately. So you need to protect yourself. This is airborne. You have to be around the patient for a prolonged period of time, but you definitely don't want to. There's medications that they would give you for it, antibiotics, but it's still nice to just not have to take the antibiotics. That's some of the things that can go wrong with your clotting processes. So, any questions on that? So red blood cells and white blood cells. I'd make sure that you kind of create a little concept map, know where they go, know how you increase their numbers, what they do, the differences, those types of things. Because tomorrow we're just going to add on to it with, again, the clotting process and our blood typing, how we go about ABO